I'd like to welcome you to the University of Washington Regional Heart Center Grand Rounds. My name is Rick Page, head of the Division of Cardiology at the University of Washington, and today it's my privilege to introduce Michael Mulligan, who is going to be speaking to us about descending thoracic and thoracoabdominal aortic aneurysm repair. Dr. Mulligan.
Thank you, Dr. Page. Over the last 2 years, the University of Washington has made an attempt to centralize the care of patients afflicted with these aneurysms. We've made great strides in improving the quality and increasing the volume of repairs that are done here at the University of Washington, and we therefore thought it would be important and timely to review the topic. Descending thoracic aortic aneurysms involve the thoracic aorta extending from the left subclavian artery and may go down all the way down to the diaphragm. Thoracoabdominal aortic aneurysms involve not only the descending thoracic aorta, but also varying portions of the intra-abdominal aorta. These are not separate thoracic and abdominal aortic aneurysms, but rather they are one large aneurysm in continuity. The history of thoracic aortic surgery really defines and aligns with the history of vascular and cardiothoracic surgery. In 1943, the first segmental resection of a thoracic aneurysm was completed without restoration of vascular continuity, and 5 years later, the importance of restoring vascular continuity was realized when excision and end-to-end anastomosis was achieved successfully. In 1950, it was no longer necessary to bring the two ends of the vessel together, but rather the gap was bridged with graft material for the first time, and the importance of metabolic slowing and neuroprotection was appreciated sometime later, as in 1956 the application of surface hypothermia was first used, and in 1957 distal perfusion was achieved using shunts and a pump for the first time. The modern evolution of surgical technique with the graft inclusion technique really began more than 40 years ago, but as you can imagine, many refinements have been made since that time, and in today's presentation we will try to review the state of the art. What causes these aneurysms? Well, far and away there are three causes that account for the vast majority of cases. Medial degenerative disease or progressive breakdown in the integrity of the vascular wall accounts for more than 2/3 of cases. Aortic dissection or insinuation of blood within the wall of the vessel itself, such that the vessel delaminates or dissects, accounts for approximately 1/4 of cases. And Marfan syndrome, which is an inherited defect in the production of type 1 collagen and or cystic medial necrosis, account for about 5% of cases. Ehlers-Danlos syndrome, which is a defect in type 3 collagen synthesis, which produces the so-called rubber man syndrome, accounts for only about 1% of cases. And there are much less common etiologies such as infection, aortitis, and trauma. Aortitis used to be the #1 cause when syphilis was running rampant and tertiary syphilis was untreated and discovered, but over the past 3 to 4 decades, that's been all but rendered non-existent. This usually leads to the development of diffuse or fusiform dilation, where you have a narrow neck at the top end and the bottom end of the aneurysm, but in the presence of infection and or pseudoaneurysm, where there is a partial breach of the vascular wall, a narrow neck develops that subtends a spheroid or saccular aneurysm, and many clinicians feel that so-called saccular aneurysms are more prone to rupture. The #1 cause of death under observation is rupture, and the #2 cause of death is cardiovascular disease. As I've already alluded to, these patients often have atherosclerosis or hardening of the arteries, and it can be widespread. Risk factors for a poor outcome, specifically rupture or other complications related to the aneurysm, include large aneurysm size at presentation, the presence of an aortic dissection, a rapid rate of expansion, and the presence of poorly controlled high blood pressure or hypertension. The natural history of these things also attests to the fact that they tend to grow predictably and they tend to grow slowly under most circumstances, approximately 1 to 5 millimeters in annual diameter increase per year. However, as I've already alluded to, but it warrants underscoring, larger aneurysms grow more quickly. They vary in growth rate by location as well. Mid-descending aortic aneurysms grow the most rapidly, and ascending aortic aneurysms have the slowest expansion rates. Now, as I've alluded to, once these things get to be about 7 centimeters in size, the rupture rate goes up precipitously, and at this point, 43% of patients will have already had a major complication. Many times that includes rupture. So you don't want to intervene once patients get to be 7 centimeters, or many of your patients will present ruptured. So you have to define some point earlier in the natural history of the disease where it is appropriate for operative intervention. And in order to determine the appropriate timing of intervention, you are weighing the risk of complications associated with surgery versus the risk of complications associated with continued observation. In the context of observation, we see death, rupture, and dissection, but after surgical management, we not often, hopefully, but we at times will see patients that will not survive the operation or the perioperative period, will suffer a stroke or devastating complications such as paraplegia. Well, how do these patients present when they are symptomatic? Unfortunately, most of the patients, slightly more than 50%, are not symptomatic, but when they are symptomatic, pain is the most common symptom. Typically, it is between the shoulder blades posteriorly. It may radiate down to the flank or even down to the groin. As the aneurysm expands, it may present with airway distress, and that relates to compression of either the trachea or the left main stem bronchus that may manifest as wheezing, stridor, cough, pneumonitis, or even hemoptysis if there's vascular erosion into the airway. Large aneurysms often are lying next to the esophagus and can cause some degree of mechanical obstruction, producing dysphagia. And if there is an erosive lesion, the blood can actually enter the esophagus and present as vomiting of blood or hematemesis. Also, the vagus nerve and its branch, the recurrent laryngeal nerve, which serves the voice box or larynx, is often put under traction with expanding arch aneurysms, and as such, patients with aneurysms in that location can present with hoarseness. These symptoms are far easier to understand when one looks at the anatomic position of the aorta relative to these other structures. Here is that nerve that goes to the voice box, and as you can appreciate, if an arch aneurysm were to expand, it would put that nerve under tension. There's the trachea and left main stem bronchus, which could easily be compressed or eroded into, and here's the esophagus lying in immediate proximity to the aorta. The diagnostic evaluation starts simply and becomes more complex and more invasive. Typically, patients are first reviewed when a chest X-ray abnormality has been discovered, and that is often a widened thoracic aortic shadow or at times calcification within the aortic wall is appreciated. However, a negative chest X-ray does not mean that these patients don't have aortic pathology. Transesophageal echocardiography allows excellent access to the proximal aorta. However, its utility in assessing the aortic arch and more distal aorta is quite limited. It is also excellent for determining whether or not a dissection flap is present within the aorta. CT scanning of the chest and abdomen is superb. It provides information about the location of the aneurysm, its extent, and the distribution of major branch vessels relative to the aneurysm. If contrast is given, information is also gleaned about the aortic lumen, presence or absence of mural thrombus or clot, whether a dissection is present, and whether or not any bleeding has occurred. CT scanning is evolving, and as rapid data acquisition, 3D reconstructions, and better resolution is available, it will likely replace aortography, but aortography remains the gold standard. It not only provides excellent information about the anatomy of the aneurysm, but also provides secondary information about any stenosis or narrowing of the takeoffs of some of the branch vessels. Unfortunately, the contrast that is used may produce renal toxicity and/or embolization of debris with manipulation of the vascular catheters can cause the same problem. If renal function worsens, it is advisable to postpone surgery until it restabilizes. These aneurysms are classified with two different schemes. Thoracoabdominal aortic aneurysms are classified by extent 1 through 5. An extent 1 aneurysm begins just after the left subclavian and goes down to involve the entire thoracic aorta and stops just short of the renal arteries in the abdomen. Extent 2 involves the entire descending thoracic aorta and entire abdominal aorta. Extent 3 starts at about the level of the 6th rib, sparing the proximal descending aorta, but does extend all the way down to the iliac bifurcation. Extent 4 starts at the diaphragm and goes to the iliac arteries. This is essentially a complete abdominal aortic aneurysm, but it typically requires thoracic aortic control for repair, and so it's included in this classification. And Extent 5 was recently added to the classification scheme and is essentially a mid-portion thoracoabdominal aneurysm. Descending thoracic aortic aneurysms are also separately classified as types A, B, and C, with a proximal, distal, and complete thoracic aneurysm classified as A, B, and C respectively. Well, we not only have to know as much as we can about the aneurysm itself and the subtended vessels, but we need to know whether or not the patient globally can tolerate an operation of this magnitude. And that requires careful organ system by organ system preoperative assessments. With regard to the cardiac system, transthoracic echocardiography is critical. It not only determines what the presence of any valvular disease and biventricular function, but we also must obtain thallium scanning, and if positive, cardiac catheterization is required. We're also routinely obtaining cardiac catheterization if the ejection fraction is less than 30%. And the bottom line, the requirement for all this is that we're trying to determine whether or not angioplasty or surgical revascularization is needed prior to asymptomatic aneurysm repair. This all relates to asymptomatic aneurysm repair because obviously when someone presents in extremis with a rupture, you don't have the luxury of doing this type of evaluation. If we could, we would, but it is impractical. Pulmonary assessment is also absolutely critical. If you think, and I will show you the exposure that's used for this operation and the manipulations of the diaphragm, and you will easily appreciate then that if patients do not have adequate pulmonary reserve, they will not tolerate this operation and will manifest respiratory failure afterwards. We obtain pulmonary function testing, arterial blood gases, and spirometry looking for an FEV1 or forced expiratory volume in the first 1 second of exhalation that is at least 1 liter, and they must not be CO2 retainers with a PCO2 of less than 45. Borderline function may be improved by smoking cessation for at least 6 weeks, antibiotics, bronchodilators, weight loss, and an exercise regimen that typically lasts 1 to 3 months. Once again, operation is not withheld for symptomatic patients or patients who present emergently. This is for elective case evaluation. After taking all this into consideration and the anatomic information that I provided as well as the background on natural history, we have developed some criteria for surgical intervention, and they include rupture, obviously, symptomatic aneurysms, and there is also indications based on size. This varies a bit from institution to institution, but in the descending aorta, patients with Marfan syndrome who have a higher rate of rupture receive intervention when their aneurysms reach 6 centimeters in diameter, and patients without Marfan's more typically at 6.5 centimeters. Patients also who have an excessively rapid rate of enlargement are operated on, as well as those who are rapidly enlarging and nearly approaching absolute size criteria. In contrast to the ascending aorta, which requires urgent operation for acute aortic dissection, acute aortic dissection in the descending aortic position does not necessarily require operation, and in fact, in the majority of cases it does not, but rather operation is pursued on a complication-specific basis. Well, that's who gets an operation. Who doesn't get an operation? Obviously, those who have an excessive risk for surgery do not get operation, but also those who have asymptomatic small aneurysms. And in that context, the cornerstone of therapy is blood pressure control, specifically with beta blockade. Serial imaging is also critically important. CT scans are obtained every 3 to 6 months when they're coming under initial observation, and then it's spaced out annually after that. And obviously, they're closely surveilled for any signs or symptoms of aneurysmal progression. Well, how do we fix these aneurysms now? Obviously, if you have aneurysms that are starting at radically different lengths of thoracic aorta and with extension down into the abdominal aorta to various extents, your incision is going to have to vary. And planning your incision is absolutely paramount to a successful and smooth operation. For extent 1 and 2 operations that are aneurysms rather, that start up at the level of the left subclavian artery, a 5th or 6th rib interspace with posterior division of the underlying rib is appropriate, and I'll show you precisely what that looks like. And for extent 3 and 4 aneurysms that start below the 6th rib, incisions at the 7th, 8th, or 9th interspace are appropriate, and this is what this looks like. The patient is put in a semilateral position because we need access to both the chest and abdomen. The incision begins under the shoulder blade, courses across the interspace, breaches the costal arch, and then rejoins the abdominal midline. This incision is demonstrating a transperitoneal approach. We here typically prefer a retroperitoneal approach, and this is the diaphragm which has been taken down to join the abdominal and thoracic compartments. The lungs are depicted here. It is of critical importance that when taking down the diaphragm, the incision parallel the chest wall so as not to injure the nerve supply, the phrenic nerve to the diaphragm, and render it paralyzed. Patients are often seen in referral for respiratory insufficiency when a radial incision has been taken through the diaphragm, the phrenic nerve has been severed, and the lung function on that side is severely impaired. In order to appropriately take care of your patients, you must come up with a perfusion strategy or a protection strategy, and there are three main schools of thought that have evolved. Surgeons at different institutions have become expert with different techniques, and some are rather dogmatic about which one is preferable. I can tell you that the so-called clamp and go technique, wherein cross clamps are applied to the aneurysm and is rapidly repaired without distal perfusion or neuroprotection, has been all but abandoned and certainly is not done at any centers of excellence. The two techniques, however, that do require specific comment are left heart bypass and hypothermic circulatory arrest. With left heart bypass, we drain oxygenated blood from the left atrium, and it is returned to either the femoral artery or the descending aorta. If you do want to return blood to the descending aorta, be careful to avoid placing your cannula near known thrombus or clot in the aneurysm, as you could produce embolization. This is partial bypass. We're taking oxygenated blood and rerouting it around the clamps, but oxygenated blood is still being ejected from the heart to perfuse the head and upper extremities. Temperature is allowed to drift slightly to enhance neuroprotection, and flow is partial. As I said, this is partial bypass, and we sequentially move the cross clamp down as we complete the operation and reimplant the vessels going caudad. One must be specifically careful with patients who have had a prior bypass utilizing the left internal mammary artery to the LAD, as oftentimes the left subclavian artery may be controlled, and if you clamp that proximally, you will produce significant myocardial ischemia. After you've achieved left heart bypass and appropriate vascular control, the aneurysm is clamped proximally and the aneurysm is opened. If there's significant difficulty in obtaining distal control due to inflammatory disease down here that makes dissection hazardous or a compromise in vascular integrity, a balloon catheter can be used for distal control. This is what left heart bypass looks like, and I think this warrants reiteration. Oxygenated blood is drained from the left atrium and then is returned to the left femoral artery, and in this scene we are seeing selective perfusion done to enhance preservation of function in the liver, related viscera, and specifically here the kidneys. And this is what the surgeon actually sees, and as you can appreciate, this is a bit complicated. It has been shown to be of marginal utility, only being effective in selected centers, and we are not in the habit of doing that routinely here. It is also of paramount importance to reimplant key spinal arteries that are typically encountered between T6 and L2, and that's what's being shown here. The right renal artery, celiac artery, and superior mesenteric artery take off to the right side of the aorta, and the left renal artery to the left side. As such, we can often reimplant those first three arteries together, but in approximately 1/3 of patients, the left renal artery must be separately reimplanted. And recall that I said that arteriography gives you excellent information about concurrent arterial stenosis and narrowing of the takeoffs of some of these arteries, and those stenoses in the renal arteries need to be addressed in approximately 1 out of 4 patients. When you're all done and the graft is sewn in, we close the aneurysm wall over that to prevent graft material from being in close proximity to either the lung or the abdominal viscera. Hypothermic circulatory arrest is complete bypass. This is a different strategy wherein unoxygenated blood is drained from the femoral vein, oxygenated and returned via pump to the arterial circulation. The left ventricle must be decompressed, or it's preferable to decompress it so that we avoid distension as the heart stops beating, and full flow is required in order to maintain adequate perfusion throughout the body. Those that use this feel that it provides an additional layer of spinal protection, but in point of fact, its greatest utility is in providing better vascular visualization and control in specific cases, notably those wherein the aortic arch has to be opened. No proximal cross clamp is required, but it is imperative after completing the proximal anastomosis to de-air the proximal aorta and then restore flow in a 65-35 distribution. The sequential movement of the cross clamp is also not required, but after reimplantation of the intercostal arteries, we typically apply the clamp to the graft and begin rewarming. Postoperatively, you can guess from what I've already said that this is a massive operation where 2 body compartments have been significantly dissected, and these patients require a lot of volume to replete their intravascular volume. As such, in contrast to many other operations that we do in cardiac surgery where we try to restrict volume, these patients need a lot of volume infused. Also, by all the dissection that's occurred down the abdomen, it's not uncommon for bowel function to be lost temporarily, and as such, we do not feed these patients for 3 days or until evidence of bowel function has returned. It's imperative to avoid low blood pressure or hypotension. Spinal perfusion has been compromised by the operation itself, and the vessels that remain must be able to perfuse under reasonable pressure. We avoid hyperglycemia because it also compromises neuroprotection, and aggressive pulmonary toilet is imperative. With regard to thoracoabdominal aneurysms, the mortality under elective circumstances is approximately 10%, and that increases to 50% under emergency circumstances. In the descending thoracic aorta, elective mortality is approximately 7%, and that goes up nearly 4-fold in an emergency. Extent 2 thoracoabdominal aneurysms are the largest and most extensive aneurysms that we see, and appropriately they have the highest morbidity and mortality rates, with 30-day mortality rates just in excess of 10% at centers of excellence. That's not just at our center, that's at all high-volume centers of excellence. There are myriad complications that can develop after operations of this magnitude, but there are a few that warrant specific comment. Renal failure develops in approximately 20% of patients to varying degrees. Fortunately, dialysis is only required in 4% of patients with descending aneurysms and 10% with thoracoabdominal aneurysms. The most notable risk factors for the development of renal failure is a preoperative creatinine of greater than 2, wherein simple cross-clamping has been used or normothermic perfusion has been used, and or when the left renal artery was directly reimplanted onto the graft. Respiratory failure develops in 1 of 4 patients and is predicted by increasing age, division of the diaphragm, particularly when it is divided radially and rendered paralyzed, and the duration of cross-clamp and increased numbers of red cell infusions that were required attest to complexity of operation, which are also risk factors independently for respiratory complications. Current smoking, or not during the operation obviously, but someone who's smoking as they, in the days immediately preceding surgery, obviously predict respiratory complications. Paraplegia is perhaps the most onerous complication associated with this type of surgery, and unfortunately, even in centers of excellence, it still develops in approximately 4% of patients, and that's about where we are, although frankly, over the last 2 years, we have not had a single incident of paraplegia. It typically develops immediately, but may develop several days later, and if it does develop, it is often responsive to CSF drainage, and I'll tell you more about that in a moment. The risk factors for paraplegia include prolonged clamp time, the presence of rupture or dissection at presentation, and obviously that extent 2 aneurysm, which is the most extensive one there is. The spinal cord blood supply is derived from multiple sources, but the key branches that we concern ourselves with are those that are encountered between T6 and L2, and as such they typically require reimplantation. CSF pressure goes up, distal aortic pressure goes down, and this imbalance significantly impairs spinal cord nutrient blood flow. Protection strategies have evolved, which have included hypothermia, intercostal and lumbar perfusion and or reimplantation, and distal aortic perfusion. We here at the University of Washington use a combination of all 3. And CSF drainage is an important adjunct, and the way it works is that by placing a CSF drain, you drop CSF pressure. The distal aortic pressure is not changed because you're not manipulating the cross clamp, but what you do is you narrow the difference in this gradient and therefore increase spinal artery perfusion pressure and enhance nutrient blood flow to the spinal cord. Well, that's a lot of information. We're not going to recap the anatomic or technical points of the operation. I think that those things attest to the fact, however, that descending thoracic aortic and thoracoabdominal aortic aneurysms are complex problems. They require complex repairs that mandate expert preoperative screening, surgical technique, and postoperative care. And obviously this is best accomplished at centers like the University of Washington that have made a commitment to establishing high-volume centers of excellence. Thank you. Thank you.
Thank you, Dr. Mulligan. I'd like to thank the audience for your participation today, and Dr. Mulligan especially for an outstanding talk. And we'll hope to see you at the next University of Washington Regional Heart Center Grand Rounds.